the noise, and we'll be back.
It's okay. It wasn't
Yes?
that bad. Okay, we could hear you fine. I think it was working
Because for me it was quite
Yes.
terrible, and it's not for me, but just thinking about you. Okay, you see my halfway slide? Do you see it?
Yes, yes.
Okay. Okay. Cardiomyopathies are a different set of diseases. Again, myocardial disease. It is mainly we talk about the volume, thick wall. But and or fibrotic, and the effect is that while it contracts well, and so the LV ejection fraction is normal, it does not relax well, making it a very severe diastolic dysfunction. So it is a trouble etiology possible of the relaxation possible. You see and gray zones is possible. There are other diseases, cirrhosis or sarcoidosis, overlap. Also, diseases, there can be genetic amyloidosis again, that makes medicine beautiful. Like if and then the blood will veins. So the patient gets dyspnea, which can to so if there is a high pulmonary pressure, there can be systemic congestion lungs in the pleura, so there can be water up in the blood is built in the pericardium. Can be sort of up 8 and or for sound due to the abnormalities in the diastole, patient can develop. There can be a distension of the jugular veins due to the stasis. Edema, as I said, lab test. Lab test again, it's is a sign of heart failure. So always when the disease is left tension due to a side specific. There can be things found on the ECG, but it's not something that makes you think of restrictive cardiomyopathy per se. As I said, the echocardiography goes with a small left ventricular cavity with a normal LV ejection fraction, large atria, and dysfunction assessment in the echo course lecture and in the practical lessons. It's not this is not an algorithm that you should know by heart, but it's just for you to know that there are different types and grades of diastolic dysfunction: first grade, second grade, third grade. Of course, the third grade is the most severe with high left atrial pressures. And here is an example, a very young girl, 25 years old. She was diagnosed at 19 with AV block, a high degree of AV block. And her atria, as you can see on the movie, are very large. The ventricles are small. The left ventricle, you see a very good ejection fraction. It's contracting well. You can see here some, these are leads, the sparkling structures here in the right atrium, and it is because of the AV block she received a pacemaker, and the pacemakers have the leads in the right cavities. So this is the typical image of a restrictive cardiomyopathy: small ventricles, large atria, normal ejection fraction. When you see the between these, the restrictive cardiomyopathy and the constrictive pericarditis. But tomorrow, again, we will be together for the lecture, and we will talk about the constrictive pericarditis, and it will be more clear for you what this differential diagnosis means. But just for you to have an idea, constrictive pericarditis is a sort of a calcified or fibrotic shell due to the pericardium around the heart. And due to this, again, the left ventricle, the ventricles do not relax well, because now they are constricted by the pericardium. So the effect is in some ways similar to restrictive cardiomyopathy, but of course you have to differentiate between the two. So now you keep this table in mind. You come back to it when you learn your lectures, but we will discuss it again tomorrow, because we will discuss also the constrictive pericarditis. How do you manage a restrictive cardiomyopathy? The treatment is symptomatic. Rarely, it can be also specific to the underlying condition. But when we talk about the symptomatic therapy, and you know that the patients have stasis, dyspnea, edema, of course, the first drugs would be the diuretics, because there is an increased volume, there is stasis. But you have to give a lot of diuretic, then the stroke volume and the cardiac output decreases, and the patients get to have low blood pressure. They don't feel well. Beta blockers, you can give them, but cautiously. Again, because when they have a small volume of the left ventricle, they try to compensate for the cardiac output by increasing the heart rate. So if you beta block to a too low heart rate, then the cardiac output, which is the product between the stroke volume and the heart rate, if both are low, the cardiac output is low as well. As I said, most of these patients with large atria, they get in the evolution atrial fibrillation, so they get anticoagulated. They need anticoagulation. And if you can stop arrhythmias, you need to do it, because they don't very well tolerate it. Usually it's not easy to keep them in sinus rhythm, but you try, and you use either amiodarone or the direct cardioversion with electric shock. And you can also use ablation, for example, if the rhythm control is poor. As I said, there can be some underlying conditions like amyloidosis, and then you treat it according to the type of amyloid. Hemochromatosis, you treat it. Hemochromatosis is the effect of iron overload. The previous students, the students which were on the our floor before Christmas were lucky to see a very rare cause of hemochromatosis. I don't know if you are here listening.
Yes, we remember. Yes, it was really interesting.
Exactly, it was from the underlying was a the disease. Just a couple of words, because I think it's important for you to hear about this disease when you are students, because sometimes practice nephrologists, there are many specialties who can take care of amyloidosis, because it is a system. Even if you are a GP, a neurologic disease, and it can affect all the or many of the organs. Remember, cardiac amyloidosis can affect, like in this drawing, the heart, the kidneys, the gastrointestinal tract, the eyes, the tongue with macroglossia, the peripheral nervous system with neuropathy, the autonomic nervous system with orthostatic hypotension, for example, the bone marrow, so there can be problems at many levels. And also just a few things here, looking at how, when you look at some specific condition leading to example, you can think heart, and amyloidosis comes up several times in this table. And this is an example of cardiac amyloidosis. You can see here thick, as I said, because this is an overlap between restrictive and hypertrophic cardiomyopathy, quite thick walls. The large left atrium and mainly right atrium in this case, some pericardial effusion here, which is quite typical for amyloidosis. The interatrial septum moving inside the ventricle. There is some like it means that the blood is sort of thickening as and these are some changes in echo. Is what we call the pseudo-infarct pattern. As you can see here, V1, V2, V3, there is no R wave. And this is like after an anterior or anteroseptal infarction STEMI, but it's not this, it's just due to, again, to the infiltration of the septum and the myocardium. And the diagnosis is put on biopsy, which can be done, of just subcutaneous fat, but it also can be done on salivary glands, on the heart, on the kidneys, and you can find amyloid. And the main forms of cardiac amyloidosis are the AL amyloidosis, which is usually related to myeloma or to monoclonal gammopathy, and transthyretin amyloidosis, which is genetic or senile. Sorry, I jumped that. And now we go to the last cardiomyopathy. So last one, a few slides, a very interesting and important cardiomyopathy, which is called the arrhythmogenic cardiomyopathy. And for a long time, it was called arrhythmogenic right ventricular cardiomyopathy, ARVC. We call it now arrhythmogenic cardiomyopathy because, as you will see, we know now that it can affect both ventricles, right and left. It is due to a change in the structure of the wall of the heart, mainly right ventricle, but also it can be on the left, with a fibrofatty replacement. So there is no muscle anymore in some places. It's patchy usually, but either fibrosis or fat. It's a rare disease, but it's very important because it can lead to sudden death, as you will see. It's genetic. It's usually with autosomal dominant transmission. I don't know. I don't have the list in front of me. Are many of you, or are some of you, coming from Greece in your series? You have Greek students? Apparently not, or not many, or not present. There is an island in Greece called Naxos. Naxos Island, if somebody visits it, I didn't visit it yet. It's a small island, and apparently there are many inhabitants who have curly, actually woolly hair. It's more than curly. It's curly and quite thick, who have this palmoplantar keratosis. The palms and plants are thickened, you see on the images, and they have ARVC, the cardiomyopathy. And it's called the Naxos form of the disease. It's autosomal recessive in transmission. And a similar form is found in South America, and that was called Carvajal. In any instance, the proteins which can be affected by gene mutations are usually desmoplakin, plakophilin, or plakoglobin, and other mutations also can be present, but these are the most frequent. Just for you to know, you won't have a question on the criteria, but these criteria of diagnosis help you understand the features of the disease. The first feature of the disease is that the right ventricle is large and larger than normal, and is associated with kinetic problems like small aneurysms of the free wall, or akinesia or dyskinesia of the right ventricular wall. The second feature is that when you do the tissue characterization of the wall, now instead of myocardium, there can be fat or fibrosis. See it also on the macro images. And we usually don't see it on the pathological samples, but we usually now see it with the MRI, which is much better, the fat and the fibrosis. On the ECG, the typical feature is negative T waves from V1 to V3 or beyond in individuals of more than 14 years old, because in children it can happen in normal hearts. Another feature in ARVC is the epsilon wave, which is a terminal depolarization wave of the QRS. It's a sort of small notch in the final part of the QRS wave, and this can be present, epsilon wave. And also there are some other technique which is called the SAECG, looking at the delayed potentials on the ventricle. It's a standardized type of ECG where you can have some measurements, abnormal measurements. Another very important feature of the disease are the arrhythmias, because as I was telling you, the main complication of this disease is arrhythmia and sudden cardiac death in the young. And actually this disease was very well described by in North Italy, now for the Italians in the group here, in the Veneto area. They saw some 2 decades or 3 decades ago that some football players were dying during they had a sudden cardiac death during the match. And as in Italy, il calcio and the football are very popular, this was big, very, very dramatic observation. especially that it happened in young people. And the groups from Venice and Padua studied the hearts of these athletes, and they found the changes I told you about. And with time, they could describe that the arrhythmias that led to sudden cardiac death were ventricular tachycardia with left bundle branch block morphology, like in this image, typically with the superior axis, negative in D2, D3, and AVF, so coming from up to down, or even in inferior axis. So this was the typical aspect of ventricular tachycardia. Of course, a family history. When you ask the patient and they say, yes, my father or my mother also had this disease, they also died young and suddenly, is also a criteria. And the interesting thing about this disease is that it can evolve in time, and at first it can be a concealed phase. Then you can see the electrical phase when the arrhythmias appear, but not the structural changes. And the structural phase is late. And if you find the patient in the structural stage, then it means that it's a bit late in the evolution, and you want to find the patients earlier to prevent sudden cardiac death. So not only you try to do this early diagnosis, by example, by screening players of different sports, competitive athletes, but also by family screening of the relatives of the patient you find first, so that you prevent sudden cardiac death in the family. And the other complication of this disease, except for sudden death, is heart failure. If the patients don't die suddenly, then they can die due to heart failure, severe heart failure, especially right heart failure, and it can represent an indication for heart transplantation. And I was telling you that traditionally it was considered the disease of the right ventricle, but now we know it is a biventricular disease, and it can also affect the LV wall. There is a possibility of risk stratification for sudden cardiac death. Most of these studies come from Italy. As I said, it has a large population of diagnosed patients. Domenico Corrado, in this case, is the main author. And there are patients with high risk. Of course, there are patients who already had aborted sudden cardiac death. This is obvious. But also patients with just ventricular tachycardia, or patients who are proven to have this disease and they have severe dysfunction of the right ventricle, of the left ventricle, or both ventricles. And they should receive an ICD, a cardiac defibrillator. It's a class 1 indication. But also other patients with some other risk factors like syncope or non-sustained VT should be considered for an ICD because they have a risk of sudden cardiac death. And now just to ask you a final question in this lecture, and could you please answer maybe in the chat of our lecture today. If a patient we see has an interventricular septum of 17 millimeters and a systolic anterior motion of the mitral valve, the diagnosis is it hypertrophic cardiomyopathy? Is it dilated cardiomyopathy? Is it restrictive or arrhythmogenic cardiomyopathy? Please vote, and if any of you want to comment also in the vote, do you think it will have an obstructive or a non-obstructive form of that cardiomyopathy you voted for? And this is the final thing of the. I have one vote. I don't know if it means that one of you is still here, if it means that only one of you knows if it's A, B, C, or D. The one who voted very correctly, and some other come, but okay, I can see more now. Okay. Okay. Nice. It's nice that those of you who are voting, I know you paid attention to the whole lecture from the beginning. If you have questions, I know wish to take a break before the second lecture you have today. You do know that there is a second lecture now soon with Dr. Mandesh on arrhythmias. I think he will give you a 15 minutes break to and we'll start around 2 o'clock for you to breathe a little. If you have any questions, you can send me via email. I will send you the lecture. I sent you the first on endocarditis. I hope you all have it. And
Yes, thank you.
yes, and I'll send this
Thank
as
you.
well. And we'll see each other tomorrow at 12:30. I hope to find a more quiet place because I hope you heard me quite well today.
Yes, we heard you.
I'm happy. Okay, if there
Thank
are
you
no
so much.
questions, you all voted A, which is correct. All who voted correctly, and it's an obstructive. I mean, we expect it to be obstructive due to the systolic anterior motion, indeed. Okay, 2 o'clock. Well, you stay, I think, and Dr. Mandesh will enter. I'll leave the meeting, and he'll be back.
Thank you very much.
Thank you.
Thank you. Have a nice day.
Thank you. Thank you.
Thank you.
Thank you.
Thank you. Should we stay on this?